Good evening, welcome to Left, Right and Centre. I'm Vishnu Shom. On the program tonight, we are joined by some of the world's leading experts for some data-driven analysis on why our declining COVID caseload may in fact be an artificial creation. Now the facts seem clear. Lower testing equals lower numbers, and with vaccination rates simultaneously plummeting, India better be ready for a third wave. Are we? That's the question. The bottom line is this: our only goal now as a nation must be to protect ourselves, not delude ourselves into believing that the battle has been won. It's not been won, not by a long shot, and we will try and explain why. Also on the show tonight, the implications of the surge of the B1617 variant, first discovered in India, now in the United Kingdom. There's a surge. Huge concerns as the country opens up after lengthy restrictions. What does the evidence so far say about how effective the vaccines are? Professor Christina Pagel, Director of the Clinical Operations Research Unit at University College London, will be joining me later on this program. But first, in case you believe that the dip in overall cases in the country now being reported was a sign that we are returning to normal, here's an unfortunate reality check, one that sadly does need to be mentioned, and it has to do with vaccination. Now, it's no rocket science that vaccines save lives. The question is, when will India be able to vaccinate our target group? Will this happen this year, or will we still be wearing masks for a much, much longer time? So do consider this. Now, India needs to vaccinate 80% of our population. That comes out to approximately 1.12 billion. Now, that's the target of our vaccination. Why 80%? Because you achieve herd immunity if you get to that number. What's the current rate of vaccination? It's frankly abysmal at just about 1.8 million per day. That sounds very impressive, but remember, we're a large country. Now, with this rate of 1.8 million, it'll take 3 years and a month to achieve our vaccination target. That would be roughly June 2024. Now, if we do have to reach the target by the 31st of December this year, which is what the government hopes to do, what do we need to achieve? We need to scale up our vaccinations to 8.95 million vaccines per day. That's about 5 times the current rate of vaccination. Think about that. Is that really going to happen? Before I introduce my panel, the other no longer rocket science detail on how to tackle vaccinations is in testing. If you test, you know the number of cases. If you don't, you will never get the true numbers. We assume that the truth is what we seek. So do consider this. Since the 1st of April to now, the number of cases was at 62,019 at that stage. There has been a 531% hike to a peak average, which we are now seeing, of 3.9 lakhs. That is a huge hike, a 531% surge. But if we just take a look at how we are doing, 531% surge, the average daily tests are only up 75%. It was 10 lakhs on the 1st of April. It's now at just 18 lakh tests today. Now, if this doesn't go up much faster to match the growing positivity rate, we are frankly just deluding ourselves about where we need to be. And the fact of the matter is, testing remains, a year after COVID started in our country, a huge, huge problem. And as we face this emergency, take a look at this. In the last several days, the number of tests has in fact been plateauing. You see it's broadly a plateau over here. It's more or less straight. This in fact needs to be going all the way up. The average number of tests which have been done, in fact today, just 18 lakh tests. Again, if you say 18 lakh tests, it sounds very impressive. But again, in the context of our country, this number is very, very low indeed. So this gives you an idea of where we are with tests. And this is the other point I wanted to mention. Our capacity to test is actually reasonably impressive at 33 lakh tests, which are possible. We are presently only doing 45% of our total capacity. Again, that begs the question, if we have the capacity, why are we not testing enough? And this really does need to be looked at very, very closely. Well, we've got a wonderful panel with us this evening on the program. Professor Giridhar Babu is with us. Thank you, sir, very much for being with us. He's Professor and Head of Life Course Epidemiology at PHFI in Bengaluru. Professor Gautam Menon, Professor at Ashoka University, also with us. Dr. Vincent Rajkumar, Professor of Medicine at Mayo Clinic, Rochester in the US, joins us as well. Three wonderful experts. I'd like to thank you very much for being with us. Dr. Rajkumar, let me come to you first. And what we've tried to do in this program is actually compile a lot of common sense questions. Some are from us and some are from our viewers. So the first question to you, Dr. Rajkumar, is the drop in COVID cases in India essentially an illusion?
Well, thanks so much for having me. And I sent a tweet yesterday saying that it appears to be an illusion. And I'll tell you why. The number of cases is, as you mentioned, proportional to the number of tests you are doing and where you're doing those tests. If you're not testing, then your case numbers will not reflect reality. Our test target should be much higher for a 4- or 5-fold increase in cases. As you mentioned, the number of tests has plateaued. Cases are truly decreasing in the cities, and probably in urban areas in the north. But we are not counting cases in the rural areas. So testing, according to most news reports, is that rural areas are not getting tested. That's number one. Number two, we have been recommending to people to just assume they have COVID and stay home because of the huge pressure on the healthcare system. We want people to go to the hospitals only if they need oxygen or they really need inpatient care, which means testing by and large, even in urban areas and definitely in rural areas, will be much lower than needed because we have told people with so many people having COVID, and right now with the new variant, one family member has it, almost the entire family is affected. We're not asking everyone to get tested because testing itself will pose risks. So I think those factors need to be taken into account, and the number of news media reports about unaccounted for deaths, they're all concerning.
Sure. I just want to go across to Dr. Giridhar Babu with my second question. Can an estimate be made of cases and deaths despite underreporting, which is widely reported to be taking place across states? How do you as epidemiologists make an estimate?
Yeah, this is the most difficult thing, Vishnu. Thanks for asking this question. So we are battling to understand to what extent we are missing in terms of number of cases, and even more complicated is by what factor are we missing deaths. So just looking at the reported numbers, if you see, while this seems to be a reduction in number of tests as a common phenomena, this, in addition to what Dr. Rajkumar said, I'll add, in terms of when the decrease occurs, where it occurs, and by what quantity it occurs, even that also seems to be very sort of a design option which is happening. I'll give you an example. There are few states where the state capitals, the testing is decreased, where the surgery is happening, and the tests are increased in other areas where probably there is low burden. And once the city starts decreasing in the surge, then there is increase in the test. We are playing with the test numbers in a way which appears to be sort of predicting how many cases I should have as a result of this testing. And I'm saying this very carefully because this is very disturbing compared to how we managed the first wave and how we managed the second wave in terms of testing. At that time, we did not have enough testing capacity, but we ramped up to make sure that we will do enough tests. Now we have the capacity, but there is this fear that we test more, there will be more cases. The Honorable Prime Minister made a request to the nation yesterday that report numbers properly. Despite of this, I don't think some states and some regions have taken this seriously. I'll make a final point here. When you do not test, especially the vulnerable people, you are actually denying them an opportunity to get treated, and therefore it is a disrespect for their entire life if they end up dying. And on top of that, we don't count their death. This is a really serious issue which each one of us should look into this very carefully.
It goes against the core of our constitution. Everybody deserves to live and get health care. If you aren't testing, you don't know if somebody is sick. And if you're actually testing in places where it works in your favor and not in places where it doesn't work in your favor, then we are deluding ourselves. And I think that's the point that you make quite so eloquently. Professor Menon, how long will India's second wave last?
It's hard to say. I mean, we've seen a downtrend in the numbers over the last 4 to 5 days. As your other panelists have pointed out, whether this is real or not is something that we don't know at the moment. We believe that testing is certainly not enough to keep up with the numbers of cases. And we don't know really what's happening in rural India as opposed to urban India, where we have a much better idea. So, insofar as models were suggesting that you should see a downturn around the middle of this month, and the data seems roughly consistent with that, I would think that yes, maybe we have turned the corner. But as I said, the really big question mark here is what's happening in rural India. Even though urban India may have plateaued, and cities like Bombay certainly have certainly come down in absolute numbers, and Delhi's also turned the corner. We really don't know whether India-wide that statement can still be made.
Yeah. In fact, this next question is for you as well. Professor Menon, is there stubborn resistance to evidence-based policy making? This is obviously a reflection of what's happened. One of our top virologists, Professor Jamil, has decided to quit the panel that he was on. I know you don't speak for him, but in terms of the government accepting numbers as they are presented by epidemiologists and by genome sequencing and by clinical and by evidence on the ground, is there a sense that they choose not to look at facts, scientific data?
I know that Professor Jamil had made this point in his article in the New York Times. I think the larger problem is in general a respect for data and the collection of data. And I think that's a problem that we're also seeing with all of this controversy about are we counting the numbers of deaths correctly? We're not testing enough to find the number of cases. So if you treated data with the respect and the collection of data with the respect that it actually required, then many of these problems would actually be solved, because then we would know where we stand currently with respect to the pandemic, and external, both people in government and people outside government, can comment based on those numbers. So I think the problem is deeper. It's not really whether a government pays attention or not to what is being told in terms of data. It's that our attitude to data itself and its collection must change.
Professor Rajkumar, is a third wave inevitable given the slow pace of vaccination?
So I wouldn't say inevitable. It is in our control. I think what we have to do is deal with the facts. The facts are that only 3% of the population are fully vaccinated, and only 10% have had at least one dose. So there's a lot of vaccinations left to be done. And part of it is going to be a logistics issue. Part of it is going to be how many vaccines you have on hand, and the duty of the West to help India in making sure that India has sufficient vaccines, because otherwise it's going to be self-defeating for Western nations. So I'll make that very clear. Number two is that we are very confident that lockdowns work. And so we have seen that now, that even though there isn't a national lockdown, most states are in some kind of lockdown, although the strictness varies. But lockdowns will work and will reduce the number of cases. When cases go down at that point, unlike the first wave, now we do have a solution, which is vaccination. And so we just have to make sure that the public is well educated, that when the lockdowns work and restrictions are relaxed, say when the test positivity goes down to less than 5%, at that point, they cannot go back to life as normal as it was in between November to February.
Right.
Then you will have a third wave. You will have to emphasize masks, social distancing, avoiding crowds. No matter what the government regulations are, people have to be careful until they are vaccinated.
Professor Babu, can India afford to wait for vaccines to be available in numbers? That's going to happen only in a few months from now. Can we wait at all? Can we wait a day?
So there are two options, Vishnu, that we need to implement. First is definitely preparing for faster and wider coverage with vaccines. And currently, even if you were to cover only the vulnerable before the next wave, which I assume may be around December, To cover 300 million 2 doses, we need to be doing at least 10 million doses per day. And in order to get the required vaccines, we have to make extraordinary efforts in getting the vaccines from outside before we ramp up the manufacture here. The second aspect is aggressive containment. We can't assume that we have controlled it and then we go back to our normal lives where it will spread out of control. Just to give you an example, as we speak, in the last 30 days, Tapi district in Gujarat, Coorg in Karnataka, Mansa in Punjab have seen nearly 200% rise in cases. While overall, we are seeing that there is decline because the larger numbers from the urban areas seems to be decreasing. The rural areas and the small districts are increasing, which means that the circulation is going on there. Until we do aggressive containment and control, at the same time in parallel do faster and wider coverage, we will not be able to have an advantage in the next wave.
Professor Menon, will reliance on antigen tests in rural areas, as is being suggested by the government, more reliance on antigen tests because they can be rolled out faster, is that not a recipe to potentially generating poor data?
No, I don't think so. I mean, I've been a strong proponent of antigen tests because they can be rolled out at scale. You don't have to, there is no delays involved. You can get your result in about 15 minutes with rapid antigen tests. And if you're just testing much, much more than you can currently with the PCR regime, then that itself is a great, is a step forward towards improving the quality of information that we have. So I would actually suggest, I think the ICMR guidelines on this point actually are sensible to ramp up and make testing much more universally available. Have little booths where people can go and get tested rather than go to hospital or specialized testing centers, and just expand the scope of testing as far as you can.
But isn't the worry there, Professor Menon, that if you're asymptomatic, you may not be picked up at all in a rapid antigen test. You would be picked up in a PCR test.
So that's a question of numbers, and certainly the sensitivity of the good rapid antigen tests aren't all that bad. You can have sensitivities all the way from 70% to 90%, depending upon the test that you actually use. And if your viral load isn't large enough to show up on a rapid antigen test, it's unlikely that you will be very efficient at infecting people. That's another way of looking at it, which has been pioneered by a number of scientists who are looking at this. But I think in general, the advantages of having much more testing over a much larger range of population outweighs the problem that the sensitivity of the rapid antigen test is lower.
Sure. Final question to you, Professor Rajkumar. There are different groups, epidemiologists, mathematicians who've modeled, fatalities. And it's a sad question to ask, but because the data is also incomplete. But based on what you're hearing, what you're reading, and your own sense, how many Indians may eventually end up losing their lives in the second wave of COVID?
I cannot tell you for sure. I think in the first wave, I had a feeling that we were underreporting deaths by a factor of 2, so, double the number. Now I feel many experts, and depending on who you ask, yesterday there was I think a good statistician who was done the analysis and figured that it was 5 times the reported death rate. Some say 10. It's very hard because we just really don't have any, other than qualitative reporting, we don't have any good hard data to go by, but there is undercounting. I hope it's lower because, my problem is, number one, we are losing deaths to COVID, the virus, but we are also losing a lot of people who should be saved, who I know we could save if hospitals were not overwhelmed. So just the lockdowns and flattening the curve will reduce the number of deaths. And finally, the indiscriminate use of steroids is really, really worrisome to me because we are seeing problems like, amphotericin B shortage and posaconazole shortage and Mucor. And these are not things that you should be hearing with COVID. And it's happening because I personally have seen so many patients reach out saying that they've been given long courses of steroids.
Sure,
so
and that is
the avoidable
overdose
deaths.
of antibiotics and other medication, and certainly steroids in this particular context, a huge concern in India. It is, I think the bottom line remains, and none of us would disagree, if you don't test more and if we don't vaccinate more, then we remain in deep trouble. The question is, how much longer will this go on? At a time when so many countries are actually opening up, it seems that we're going to be wearing a mask for the indefinite future at this juncture. I'd like to thank you all very much for joining us. Well, one of the countries where there is a surge of the variant, which was first discovered in India, B1617 as it's known, is the United Kingdom. The numbers are surging, and this may well end up being the top strain of COVID-19. So what are the implications in the United Kingdom, and what are we learning in terms of the strain itself? Before I go across to Professor Christina Pagel of University College London, I'd just like to go through a couple of these numbers. What you see over here, a couple of areas in the United Kingdom, the older strain of COVID, the numbers coming down, but variants of B or subvariants of B1617 on their way up. This is in the east of England, and it's very much the same in a couple of other parts. Now, if you look at London, this is actually, according to the data now coming in, gone beyond the older strains, B117 and the old wild strain, as it were, to be the dominant strain in the city of London. Similarly, in the northwest, there are signs of this being, again, dominant, going beyond what the old strains were. And finally, in the southwest of the United Kingdom, once again, this very rapid rise of B1617.2, which is a subvariant of B1617. I'd like to go across to Professor Christina Pagel. Thanks very much, Professor Pagel, for being with us. Based on what scientists in the United Kingdom are now saying, do existing vaccines actually work against this strain?
So we're still waiting for kind of definitive evidence on that. But the early signs are that, yes, the vaccines work in preventing severe illness, which is the most important thing. There are some indications that they're not as good at preventing transmission. So it looks as if people who are fully vaccinated could still potentially catch this strain and pass it on to other people, even if they themselves don't get sick.
Yep.
So that means it just makes it a bit harder to control overall because there's more transmission.
Why did the United Kingdom bring down the interval between vaccine doses? What was it in this particular virus that resulted in this tweak?
So it's the fact that this variant is now doubling every week in England, and that's been happening since the last 6 weeks, so quite a consistent trend. And it won't be too much longer before it probably becomes dominant. And what they're worried about is that then causing another surge of infections that could, just because of the sheer numbers, start affecting people who've only had one dose of vaccine, who are more vulnerable. So what they're trying to do is protect those people now, so that by the time this variant does become dominant and cause another surge, then we'll have more protection.
Yeah. How soon before the strain does become dominant across the United Kingdom?
Well, not that long. So there's data released today by the Wellcome Sanger Institute, which looks at just community cases. So it tries to take out cases that we've sequenced from travellers entering the UK, and also from surge testing, which is what they do if they identify an outbreak. And that says that in the week to the 8th of May, this variant was 30% of cases in England. So, probably by June, we might be at 50%.
Yep.
What's kind of unknown is that today we're having a big unlocking. So we're now opening up indoor spaces across the country. So how that's going to affect transmission isn't really known, because what's happened is it's not just that this variant is increasing, it's that the other variants are coming down. And so that kind of makes it look like the proportions are increasing faster than they would otherwise. But if the old variants now go up as well with more mixing, then it's all a bit kind of confusing.
Yeah, no, in fact, that's an important point, because, for example, here in India, we had B117 and B1617 at the same time, and in different parts of the country, and the wild strain as well. And then, it was terribly confusing for people to actually understand what they were dealing with. But the United Kingdom is opening up. It started opening up now. In your opinion, how dangerous is it for restaurants and pubs and whatnot to be opening up at this stage?
So, that's a really good question. So I think from an individual point of view, so from an individual person, it's not that dangerous to go to a restaurant or a pub, simply because cases, although they've been going up of this variant, are overall still quite low. We're still at levels that we last saw last summer in the UK. But from a population perspective, public health perspective, it's quite risky, because we know that will just accelerate spread. So we know that by opening up now, we might then cause ourselves to be in a bad situation in 4 to 8 weeks' time. And if our vaccination program hasn't managed to vaccinate enough people, then we could be in trouble. And that's according to the government's own scientific advisors.
Yeah. One final question, and I saw this this retweet of yours today, and I'm trying to understand the science of what it leads towards. Why is new data on neutralizing antibodies key to understand the efficacy of vaccines going forward?
Yes, so ideally what you want are real world vaccine studies where you look at people who are getting sick, going to hospital and dying, and looking at what strain they had and what their vaccination status is. But that takes a long time to come through, like months after a variant has been identified, and that's just too long. So the laboratory studies, what they do is they take virus and then they take blood samples from people who've been vaccinated or have had COVID, and they kind of pit them against each other and see how many antibodies are produced. And so it's not perfect by any means, because it doesn't tell you about severity of illness or anything like that. But what a study that just came out today in Nature shows is that actually those lab studies looking at antibody effectiveness are actually quite well correlated with later studies looking at real world effectiveness. And so basically what it means is that those kind of lab studies give us quite an early indication of how well the vaccines will work in the real world. All
right. Thank you very much, Professor Pagel, for being with us this evening, giving us a sense of what you're seeing in the United Kingdom. And we follow what you write very, very closely indeed. Thanks very much indeed. We're completely out of time on Left, Right and Center this evening. It's time for this short break.